Namaste everyone. Today I'm talking the nasopharyngeal carcinoma. This is the one of the topic in cancer in nasopharynx, which is Epstein-Barr virus related. I will highlight the topics regarding nasopharyngeal cancer and its treatment and etiological factor. Let's go together. Okay, definition wise, it is a malignant epithelial tumor arise from the nasopharyngeal mucosa, most often from the fossa of Rosenmuller. As a student, you have to know fossa of Rosenmuller. This is the pharyngeal recess in the posterior part of nasal cavity or nasopharynx. What are the risk factor or etiology? They may be Epstein-Barr virus. Everybody should know Epstein-Barr virus infection. There is a genetic predisposition, HLA-A2, HLA-B17. In southern China, there is most of the people take salted fish. This salted fish, which contain nitrosamine, that can cause cancer. As it is endemic in southern China, which is described in the Scotland, in the Sichuan province. There may be sometimes there's a chronic nasopharyngitis which can further develop cancer. Smoking and poor nutrition also give the risk factor, but not like Epstein-Barr virus. So first you have to mention Epstein-Barr virus, then go to the genetic predisposition, then salted fish. Okay. Next, what are the age, sex, and common site? This is the bimodal type of disease. This is occur 10 to 20 year, and later on the 40 to 60 year in the same population. It is higher in the male compared to female, almost 3:1. Common site, this is fossa of Rosenmuller. Rosenmuller. Remember this fossa of Rosenmuller, which is lying the lateral wall of the nasopharynx. Remember that one. Okay, fossa of Rosenmuller, which is lying the lateral wall of nasopharynx. Histological type, WHO classify it type 1, type 2, and type 3. Type 1 is keratinized squamous cell carcinoma, whereas type 2 non-keratinized type of cancer, which is differentiated one. Type 3 is undifferentiated. There may be lymphoepithelioma, which is EBV, Epstein-Barr virus related. This is the most common one. Clinical feature, a professor can ask, what is the most common presentation of this disease is cervical node metastasis. They estimated that 60 to 75% cases there is a cervical node metastasis, maybe unilateral or bilateral. Nasal obstruction is second one. Don't jump in the nasal obstruction is the first one, or epistaxis. Most of the students tell there is epistaxis. It's not epistaxis first one. You have to tell cervical lymphadenopathy. Third one is oral conductive hearing loss, tinnitus, ear fullness. This occur due to statue blockage. Why this happen? Examiner can ask why there is a hearing loss in nasopharyngeal CA. You have to mention due to statue tube blockage. Cranial nerve palsy, there are so many nerves involved in this disease. Most common is abducent nerve affected, then ninth nerve, 10th, 11th, 12th nerve in advanced disease. Remember, first one and most common is abducent nerve. There is a constitutional or metastatic symptom also. It may be weight loss, bone pain, or cough. So again, I emphasize, there is so many exams. They are asking you, what is the commonest presentation? And I focus again here, this is the cervical lymph node metastasis. Where? Bilateral. And which group of the lymph node? Sometimes tertiary level question come like that. You have to answer posterior triangle lymph node. Route of spread. These are the direct extension of the disease that is already in the nasopharynx, it go in the skull base, sphenoid, and parapharyngeal space. This gives the canyon of palsy. Lymphatic spread, it can go the cervical, upper cervical lymph node, and posterior cervical lymph node. This is the most common route. Hematogenous spread, bone, liver, lung, and distant metastasis. Investigation, we have to do nasopharyngoscopy to see the mass in the fossa fluenza. If there is a mass, we can take the biopsy from there and send for the histopathology. That confirm the nasopharyngeal carcinoma. CT and MRI will look for the local extension of the disease and involve the skull base. Skull base cases prefer to do CT with MRI. Epstein-Barr virus serology can be done, and which is done by PCR, which help in the diagnosis. PET-CT for the metastasis of any kind of head and neck cancer. It is one of the tools to see the recurrence after treatment or primary disease too. Treatment, please do not forget, this is the line you have to tell in the exam. Must. So radiotherapy. What is the mainstay of treatment? It is the radiotherapy. It is radiosensitive tumor. Concurrent chemotherapy. Yes, cisplatin based for advanced disease. Don't tell the first one, this one. Tell, or you have to come with radiotherapy is the mainstay of the treatment. Surgery, yes, for recurrent and persistent disease, if not controlled by other means of treatment, we can go surgery. It is the last one for recurrent and persistent disease, not for primary treatment. Prognosis is good for non-keratinized and undifferentiated type, or if there is a cranial nerve involvement, almost distant metastasis. So what are the why highlight? Here you have most common site. This is the fossa fluenza. Most common presentation, neck mass. Which neck mass? Posterior tangle mass. Posterior tangle mass, lymphadenopathy, that should be bilateral. Most common cranial nerve involvement is the set nerve, which is a radiosensitive tumor, is undifferentiated carcinoma. What is the etiological agent? This is the Epstein-Barr virus infection. What is the endemic region? It is the southern China, especially Sichuan. Okay. We highlighted the nasopharyngeal carcinoma. Thank you for the today's session. Thank you.